here with Audrey Gibson, and I'm Lori Reed. And I do want to thank Boehringer Ingelheim for helping to support this program and bringing us together. And so we're going to use 2 case discussions tonight to talk about the journey through ILD in rheumatic disease. The first case, I thought RA was just about joints, how we're going to be able to recognize and manage the RA-associated ILD. So we have LBJ. He's a 67-year-old male, presents to clinic complaining of some fatigue and some shortness of breath. It's been a little bit mild. Over the past 6 months, he kind of thought, well, should I even mention this? But he's been suffering with it, and his wife's been like, gosh, you're just more short of breath. I had noticed you've not been able to do so much. He has a medical history that maybe Audrey wants to tell us a little bit about.
Yep. So he is a seropositive rheumatoid arthritis patient who was diagnosed around 4 years ago. He has a very high titer rheumatoid factor and a very high titer anti-CCP, so very positive for rheumatoid factor and CCP. And his medication course for his rheumatoid arthritis kind of follows what we typically see for patients. He was initially started on methotrexate, and then I'm assuming probably had persistent or ongoing joint inflammation. And so they escalated therapy and added adalimumab about 2 years ago. And so his kind of combination is this combo therapy with anti-TNF and then DMARD methotrexate. So, when we see this patient in the clinic, he's got new onset cough, shortness of breath, been ongoing, plus this history of rheumatoid arthritis. And that kind of starts to set off some alarm bells for us. So, which features of his history suggest that this patient may be at a higher risk for ILD?
Trying to remember all of your room stuff from last year, but it's the high titers, isn't it?
Yes. So that is one of them. We know that patients that are seropositive with very high titers, that can be one of the strongest predictors of patients with rheumatoid arthritis that develop ILD. The duration of his disease is another factor that kind of is concerning for us. So he was diagnosed 4 years ago, and that, kind of cumulative inflammatory burden can really increase the lung risk over time. This patient, he's an older patient. So again, the age puts him at an increased risk. So especially that patient that's greater than the age of 60, right? We have to worry about ILD in those patients with new onset or increasing shortness of breath or other respiratory symptoms. And then the fact that he's a male actually also significantly increased his risk as well, and can predict for poor outcomes. They don't mention it here, but if he were a smoker, that also would increase his risk as well. But we don't know that information from his past medical history. It just wasn't given. Any other thoughts or anything that stands out to you about this patient?
I think what just hit home for me is that when I see patients, I need to not just know, oh, they've got RA, but I might need to investigate a little bit further and understand their levels, how high their titers were or not, and when they were diagnosed.
Yeah, absolutely. Yes.
So, and Dr. Westney, please feel free to jump in, and we'll just make this conversational if you'd like. So, furthering the exam, they do hear inspiratory crackles when they listen to his lungs. His oxygen's normal at rest, but they walked him, and he did desaturate when he was walking. They obtained a chest x-ray that did show some interstitial markings. That's very vague and broad. It does not say where. And they also got pulmonary function testing. So the 2 numbers I tell patients that we really, really pay attention to when we're looking at pulmonary function testing and interstitial lung disease is their forced vital capacity and their diffusion number. So a forced vital capacity is normal above 80%. This gentleman's already at 65%. And then this diffusion number is also low at 41%. So with all that, I'm glad that they continued their investigation and they got the high resolution CT scan, which is really important to make sure when we're investigating these patients that we get the high resolution CT scan. I actually put in the order too. When I put the order in, I put ILD protocol. So they can try to get prone and supine and inspiratory and expiratory imaging so we can get the clearest picture of what the patient's parenchyma really looks like. So on his high resolution CT scan, there was basilar predominant reticulations with honeycombing, which is consistent with a UIP pattern. So I know what this means in my world. Audrey, if you saw this on a patient CT in your clinic, what would you think?
Yes. Again, if I first off, I want to just say this is a primary care evaluation, and I'm actually, that it's kind of impressive to me that they would go in and go ahead and get a pulmonary function test and go ahead and get a high resolution CT scan. So kudos to whichever PCP this was. And I know from my own clinical experience, and I just want to ask you from your clinical experience, I would say that in most cases, my chest x-rays are probably not really helpful in this particular patient setting. So a lot of times I will get chest x-ray on patients and they are fairly unremarkable. But because of that patient's potential high risk and because of some of the other features, I will go ahead and get a high resolution CT scan. And then you see those changes that are consistent with ILD on it. So I do want to make that point. Is that something that you see in your practice too?
Yes, it is very common that the chest x-ray is not helpful in making the diagnosis, but it can also be very helpful in ruling out other etiologies and ruling them out up front. But I think that what a lot of our patients kind of work through and experience is once the chest x-ray has been done and maybe somebody says, oh, it's pneumonia and treats them, and then the symptoms persist. And so they get another chest x-ray and they're like, oh, well, this pneumonia is not resolved and treat again. I don't think that it's being, I think using it as a rule out tool and then escalating to the next investigation was most important.
Yeah. Yeah. So, if this were one of my patients and I got a CT scan that looked like this, my first thing is I'm going to refer to pulmonology. I'm going to call my best pulmonology friend and say, hey, we've got a patient here. And, really, I think setting up that multidisciplinary team, that kind of co-management between rheumatology, pulmonology, maybe even radiology, depending on where you're at. I think that's really, really key. That kind of early referral is really, really important here. And then I think depending on your location where you practice, I think that kind of helps with, your recommendations in terms of those guidelines, who's going to follow, right? Who's going to follow the CT scan? Who's going to follow the pulmonary function test? If you're in that large academic setting where you kind of all have that ability to work together, I think that's ideal. But of course, if you're living or if you work in an area that maybe pulmonology is not as readily available, then you kind of are in charge of some of those screening tests. What about like 6-minute walk tests? We don't have capability in my office to do those. Or that's something that you guys are doing in pulm in addition to the pulmonary function test and the high resolution CT scan. Yeah.
Yeah. Mm-hmm.
Yeah.
Certainly determining their oxygen level with the pulse ox and then the 6-minute walk test to, just get that baseline, baseline reading to use that as therapy, to see effectiveness of therapy.
Yeah.
Yes.
And I would say if I hear crackles, they're getting a CT scan. I'm skipping over that chest x-ray.
Same. I'm the same. Now, sometimes I have to do the chest X-ray for insurance purposes,
Yeah, that's true.
but I'm with you. If I hear crackles, you already know that there's some damage there, and you kind of have to be a little bit more aggressive, I think.
No. Dr. Westney, do you have any difficulty getting the high-res CTs?
We haven't. But you did mention that ILD protocol, and many times, so you're saying at your institution, if you order high-res CT ILD protocol, you're automatically going to get the prone, the inspiratory, expiratory, and so that's something we still need to work on. Sometimes we need to just spell it out. And
Yes.
this is what we want. So
yeah. So I think that our radiology department has gotten used to it because
yes,
we would spell it out in like the comment section of the order. And I'm still kind of in habit of doing that, especially if patients are going to a different center to get their imaging.
Yep.
Well, Audrey, you mentioned next step, call a friend, get to pulmonology.
Yes. Phone a friend.
Yes. Referral to pulmonology is the next step, confirming the diagnosis. So this patient has been on methotrexate for 4 years and adalimumab for 2 years. This kind of recaps his high-risk features with the high titer, the older age, the male sex, the anti-CCP positivity. So we've talked about the baseline. We got the walk and the PFTs, we got the chest X-ray, and then the high-resolution CT scan. I think all of that's really important for a good, solid baseline to know where we're starting. Would you continue the methotrexate?
This is a loaded question. So there's been so much study, so much research, concerning methotrexate and ILD and, potential causative issues in the lung. And I think some of the newer literature, is really showing that methotrexate is not causative in chronic ILD. However, that being said, there is definitely limited benefit, I think, of methotrexate once ILD is established in those patients. And we know that other medications are more effective in the lung tissue. And so because of that, then I will generally stop the methotrexate and change to a different DMARD or another drug that is probably more favorable in the lung tissue. And then I also kind of have a secondary reason why I discontinue methotrexate in those patients because I don't want there to be any, what's the word I'm looking for? I don't want to, I want to take away any potential thing that might be causative or increasing of respiratory symptoms. So if I leave the methotrexate and then patients have worsening shortness of breath or respiratory symptoms, then I have had, pulmonologists and other specialties in the past say, oh, well, that's probably what's causing it. That's from the methotrexate. So this way, if I stop it and discontinue it, I don't have to worry about that. I can take that off the counter. And then I think, sometimes also, if you're not sure in a patient, whether it's ILD or maybe a pneumonitis, then it definitely in those pneumonitis patients, you want to discontinue methotrexate too. So I'm curious to see or hear from your side kind of how you feel about methotrexate.
Same. I'd echo the same, that if we know that, in the I was going to say PH-ILD, in the RA-ILD space, it's not the strongest, strongest treatment option, and it does muddy the water, that it wouldn't be the best choice for the patient. So we favor switching, and we have those conversations with rheumatologists and make it a shared decision between us, rheumatology, and the patient. And usually patients don't mind.
Right. They're usually okay with it.
Yeah.
I would agree too, because methotrexate, it's like you say, muddy the water. Yeah. You can take it off the table and just really see.
Exactly.
Right. So this patient we stopped methotrexate, switched to
Abatacept.
abatacept.
There you go.
Thank you. And initiated nintedanib, antifibrotic. We also need to make sure that we're reviewing the whole patient. Are their vaccines up to date? What other therapies and treatment strategies are we using to help support them now? And then what's our plan to continue to monitor them? So we've stopped one immune suppression, started another, and then started the antifibrotic. So in this patient with all those changes, I would generally have them come back in 3 months and repeat PFTs and see how they're feeling, what their shortness of breath is reported as, and then march on from there. So kind of summary high points for this patient. The high risk RA patient, I think from a pulmonary perspective, we need to, I'm more aware of their high titers, and we need to be more proactive in screening them for ILD. Using the high resolution CT and the diffusion number on their pulmonary function testing to really identify early subtle changes there. The UIP pattern carries a poor prognosis in patients with ILD, and knowing what those patterns are and seeing them and understanding that adding antifibrotics early on can save lung. And so that buys time with the antifibrotics slowing disease progression. And then using our phone your friends and our network to bring specialty care in a multidisciplinary way to talk about patients. Any questions or thoughts as we wrap up that patient?
Super good.
All right. So, Audrey, do you want to take this one?
Yeah, I'll take this one. So this one is our second case. It's the last case. And so this is in a patient with systemic sclerosis with progressive ILD. And she comes into your office and she's really having more respiratory symptoms, more difficulty, harder for her to breathe. And we're going to kind of go through her workup here. So she is a 56-year-old Caucasian woman. Her chief complaint today is worsening dyspnea over the past 6 months, along with dry cough. Her past medical history includes a known diagnosis of diffuse cutaneous systemic sclerosis for the past 2 years. Oops. And all right, next slide. There we go. And, so you do your clinical exam on this patient and you see that skin thickening proximal to the elbows, very classic of systemic sclerosis. The patient has a history of Raynaud's as well as GERD, which we also readily and often will see in this patient population. Her labs are positive for an SCL70. And so in this setting of patient with systemic sclerosis and her worsening respiratory symptoms, we're in a rheumatology clinic. We are already kind of starting to kind of do that workup in our head for possible or developing ILD. And so there are several features of her history and her symptoms that are pertinent and important for us to consider of her risk of developing ILD. And one of those is that she does, of course, just having diffuse cutaneous systemic sclerosis puts her at an increased risk, higher than some of our other rheumatic diseases. It can be one of the strongest clinical predictors of ILD. She also has a positive anti-SCL70 antibody, which is associated, we know, with higher ILD prevalence and can even be more progressive disease. And then, of course, just her worsening respiratory symptoms. If a patient comes in and she says that she can't breathe, she's having more shortness of breath, that is automatically put in kind of my differential. And I think one thing that might not be quite as obvious is that she also does have some GERD. And sometimes that chronic like almost micro aspiration, it can contribute to that lung injury, which can increase her risk for ILD as well. So all of those things kind of play into that potential or increased risk for ILD. Anything else that stands out for you in this particular patient?
No, the positive SCL70 and the cutaneous systemic sclerosis, I think, just automatically raises red flags.
Mm-hmm.
The GERD is very interesting, and a lot of patients will say, "Oh no, I don't have it. I don't have it," and I have to. I don't know which article or where I really found this, but almost 50% of patients who have been diagnosed with reflux don't have symptoms,
Mm-hmm.
but they still have it.
Yes.
And so that's almost a harder sell with patients.
Yes.
Um,
I've run into that myself, actually.
yeah.
Yeah. Yeah, this whole thing with GERD, I think, in fact, I've heard some of my family practice guys say, oh, just treat it. GERD is, they kind of don't associate it with, some of these other things. And yeah, it can be. A lot of our patients, they don't have the symptoms. Maybe we're not asking the right questions, but
Right.
yeah, oh no, I don't have reflux. I'm fine. But then see, the pattern on CT, and it's like you just want to stamp out any possibility, for
Absolutely.
Right. Yes. And so then I talk to patients. I usually say, this is one of the things that is a little bit of a pill and a little bit of a lifestyle change that's really easy, especially when we're talking about immunosuppression and ILD.
Yes.
So some of the baseline screening is the pulmonary function testing and the 6-minute walk we talked about with our first case. So this lady did desaturate with walking, and her pulmonary function testing does show a reduced forced vital capacity and a reduced diffusion capacity. And this suggests that she has had these pulmonary function testing before, which is great because that means maybe she was sent for screening PFTs at time of diagnosis. So maybe we have something to compare it to. But these are both downtrending from her baseline. And then she did get a high resolution CT scan that showed early honeycombing in a UIP pattern. So next steps, I know what I would do from a pulmonary perspective. I would think about antifibrotics. I would think about oxygen support. I would think about ruling out anything else that can contribute to worsening comorbidities. I would think about pulmonary rehab and having her get enrolled in pulmonary rehab. From a rheumatic perspective, where would you go, Audrey?
Well, definitely with this patient, I would also probably do an echo on her screen and for pulmonary hypertension. That would be one thing that I would do for sure. Really strong GERD management, I think, is also really important. So I would do that. And then kind of the other step is to assess, does she have a degree of active disease that we maybe need to either change or escalate her underlying, immunomodulatory therapy in order to get her under a little bit better control. So those are kind of from a room standpoint. And then to your point too, are there any kind of like environmental triggers? Are there any, does she smoke? Are there things that we also need to talk about, lifestyle modifications to kind of help her have the best outcome possible?
Yeah. So it looks like they did initiate mycophenolate, and then the referral to transplant. That's always in discussion. What I tell patients, it's always a part of the plan. So when we make the diagnosis of ILD, I talk to patients about transplant and making sure that they understand that what they have is something that can progress, and we can't guess at how quickly or how slowly that may be. But we want to make sure that we do everything we can at each step to make sure that they're taken care of and they have support. And so for this patient, a referral to a transplant clinic so they can go ahead and get established, I think is appropriate. Other things that we hadn't mentioned also, again, are reviewing the vaccines and making sure that she's up to date on that. And then introducing palliative care, which I think may make some patients really confused if we talk about transplant and palliative care, because a lot of my patients think palliative care is hospice, and it's not, right? And so I like the introduction of palliative care early also. Palliative care being care for the patient with a chronic health condition. And so I tell our patients, I said, the 18-year-old with diabetes qualifies for palliative care. I tried to pick a young age that's still an adult that, has something that's kind of relatively common. Yeah.
And, in my experience with palliative care, as they became, more and more on board, I think, they're moving more toward the palliative care for chronic support of chronic disease. Because when it did come out, we were, it was okay, you're on your hospice track and we're not doing anything active and not looking for new, approaches to support your disease. But
Right.
I think it needs to be pushed more along all levels, and because like in the ICU, we still, when you call palliative, it's like, okay, patients do think that, oh, all right, the team is kind of giving up and
Yeah.
Right.
you move to step down and just, so,
Yeah.
yeah.
No, if I have to introduce palliative care to the patient while they're still in the hospital, I generally take it from the approach of, I want you to establish a relationship and I want them to help us all understand what your goals are and go ahead and set those goals so that we know what we're supporting you to. And then in the outpatient world, I talk more about, this is somebody who can come in and help from a forest view, add things that can help the symptoms, like using Focalin for the fatigue that these patients have, I'm like, well, I don't know that I want to be the one prescribing Focalin for the fatigue for this, but I'm so glad that I have palliative care that you can go see and help manage that. And so then continuing to monitor and adjust therapy. And so again, this patient we would follow, every 3 months and get PFTs and manage symptoms and get the walk and follow that trend, and adjust, the oxygen. They're already on antifibrotics. And so these days we have 2 antifibrotics. We could add on another if we needed to. So from her case, recognizing again that patient that's at high risk of developing ILD, and then the importance of early recognition. Early recognition is saving lung and gaining time. Initiating the immunomodulator therapy and when to add the antifibrotic. And then the timing of the referral to transplant, and referral to palliative care and use of the antifibrotics. Any other key takeaways or thoughts?
I think, from a rheumatology standpoint, and, I always tell this, whether it's with students or whether I'm, doing a lecture on ILD, I think the most important thing is that, you really have to, look and ask, about it. I think your threshold should be very low, to consider doing some of these other additional testing or screening. And I think probably most importantly is that you do have to listen to the lungs. You have to have your stethoscope. You have to listen to the lung in order to see or to hear if you hear any of those crackles. It's very, very important, even in a rheumatology clinic. And then I think the second, or probably the other big takeaway, is just to make those connections, to make those relationships. So, if you yourself don't feel comfortable to order a pulmonary function test or a high resolution CT scan, that you have that pulmonology colleague that you can reach out to and say, hey, I have this patient and I think they're at high risk, and I think they need a workup. And so that you can get them into the right place to be monitored and managed.
Yeah. Yeah. I agree with all that. And making sure that we're utilizing the pulmonary function testing, recognizing the serologies and the high resolution CT and the cross specialty collaboration. I had a patient in the hospital, an ILD patient that had some heart failure and getting workup for PH-ILD. And cardiology was on board, and we had diuresed a bit. And they were listening to the lungs and calling them crackles and needing diuretics. And so I've politely exited the room with them. I said, well, I'm really concerned those are rails because we know she has the ILD. Just to make sure that everybody was still, on the same field. So even if it's not rheumatology or pulmonary, we have to have these relationships and network with other specialties to make sure that we're really making sure we're taking care of the whole patient.
Absolutely.
That kind of brings us to the end of what we've had prepared to present and talk about. Dr. Westney, if you have any other thoughts or insights?
No, I think this was very helpful. And I think for me, like I say, going back to the palliative, you're getting that whole, that slide where, the whole approach to the patient is good because, it's been clearly, fragmented in not too distant past, been kind of fragmented, and I think it's important to have that stick a complete kind of approach and help the patient understand that, help them understand.
Absolutely.
Be interesting to see how outcomes, are affected by that. Because really it's, when I look back, it's been kind of bad. The patients haven't done well. Some of my UIP patients. So maybe we can see some change in the trajectory, their outcome.
I hope so.
That's the goal.
I do too.
Yes, I hope so. Early recognition, I think will go a long way. And then support so that the patients can get the tests and the follow-ups and the medications and everything that they need. And that's a bigger
hurdle.
Yes, bigger hurdle, bigger conversation.
Yeah.
Well, I appreciate you coming back with us. And Audrey, thank you for presenting with me again. And I really appreciate RAP and APAP and Boehringer Ingelheim for helping bring all of this together. And I look forward to the opportunity to do this again. Yes.
It was so nice to meet you guys. And thank you for, again, just kind of joining us through this little discussion.